Just tell us when we start. Good afternoon. Welcome to Asian Institute of Gastroenterology and AIG hospitals. Medicine has always been about sharing knowledge and also updating ourselves, and also about personal experiences, especially during crises like this. We at AIG have been persistently been on this to update knowledge and about the current COVID emergencies that are going on across the world. As a part of this COVID update crisis, today we have with us Dr. Ale Tung Cheng from Madrid, Spain, who is a clinical physician and an interventional physician who has been working with the patients in the COVID crisis in one of the worst affected areas in the world. Not only this, Dr. Chen is a COVID survivor. Today we have with us Dr. Chen, who is from Madrid, Spain, who is going to share with us his experiences as he was going through the COVID crisis himself, and at the same time, he will talk about a very useful interventional modality, a very simple interventional modality that we carry out in the intensive care unit, ultrasound, as compared to the other very highly sophisticated cross-sectional imaging that we have today. Ultrasound seems to be one of the cheapest modalities to have to follow up these patients in the intensive care units. Dr. Chen has extensive experience with this use of ultrasound in COVID patients, and is going to share with us his personal experience through the COVID crisis himself, and also about the use of ultrasound in COVID patients in these periods of emergency. So the screen is all yours, Chen. It is Dr. Chen from Madrid, Spain.
Thank you very much for your kind invitation. And really, it's my honor and pleasure to share some of the thoughts I have around ultrasound and COVID. So I'm gonna share the screen of the presentation and we can start. Sorry. So can you see it, right?
Yeah, absolutely, Chen. I can be able to see the slides very clearly.
Okay, great, thank you. So this is the overview of my presentation. I'm gonna talk first through the use of ultrasound in diagnosis, then to talk about how to use it for follow-up, and then final words about therapy guidance, if it can be of any use. First of all, I don't have any disclosures. And this is the updated Johns Hopkins page about coronavirus. This morning we had at 8:30 a.m. in just a couple of minutes ago, we have a total of almost 2 million confirmed cases with a death rate around the 200,000. And in India, you are doing pretty well, 10,000. In Spain, we have 170,000. So that is the magnitude of the problem we are facing, a crisis like never before. And so the needs to have many extraordinary measures to be implemented. This is my hospital, a hospital, tertiary hospital in Madrid, Spain, with the emergency area with many isolated boxes that at the beginning of the crisis, we only had 2 box, 4 and 5, 2 isolated rooms to treat this patient. And as the crisis went over, we started to need to restructure the emergency department with many rooms, with many beds as the cases increased. We even started to use outside the hospital, an outside tent to treat these patients, the gym, and even the cafeteria and the library to treat them, to put chairs, beds, and to see these patients. So we moved from a couple of confirmed cases at the beginning of March to more than 300. How can we use POCUS in the point of care ultrasound in COVID-19? This is my hospital algorithm to treat suspected cases. As you can see, we use the X-ray, chest X-ray to triage them, but also the oxygen saturation, and another pillar that is in any disease, no difference in COVID-19, is the physical examination. And of course, the CPR to test for COVID-19. But the problem is that with any sono believer like me, that I love ultrasound because has made me a better physician, I was wondering how can I incorporate the ultrasound in this algorithm, because I know it is useful. The evidence is out there in many other viral illnesses, lung disease. So how can we do it, incorporate it? And the thing came up after having two thoughts about the disease. The first one is how good is our physical exam in this disease. So this is a COVID-19 patient. You can hear the right lung. So that was completely normal. Let's hear the left lung. So if I had to guess if my patient had lung involvement according to the lung auscultation, probably my sensitivity and specificity will be really, really low. So let's take a look at the same patient with ultrasound. Voila, we have a clear B line with consolidation right there in the same spot I was auscultating seconds ago. So we move forward to the next pillar of the diagnosis, the radiation studies, chest, CT, and X-ray. If you had the same thought I had when they presented the Chinese protocol to me, that they did a CT scan to every single suspected patient, we will come up with two problems. The first one is the resources. As the number of cases increase up, you don't have CT scan for everybody. And even if you had it, you will be concerned about the second problem. Can you use it for anybody? Pregnant, kids, and even the most sickest ones, the unstable ICU patients. So that was my main concern. So this is another patient with a normal chest X-ray, because if you cannot do CT, the next thing most available is X-ray. So here you have a normal chest X-ray, and then you have the ultrasound. The ultrasound, you see an irregular pleural line with many B lines, and below you have a subpleural consolidation, very clear all the findings. Although this wasn't a COVID-19 patient, this was a measles confirmed patient, but the findings, the ultrasound findings, are the same as any other viral illnesses. But right now, because we are in a pandemic situation, anyone who comes with these findings, probably the positive predictive value will be really, really high. Let's talk about the safety of using ultrasound in COVID-19. We have two types of ultrasound devices. We have the card-based and the handheld. The card-based are the ones who has a card and we have to carry all along, and then we have the handheld which we can put in our pockets. In this kind of situation, if we can choose, it's better to use the handheld. And let me explain why. The card base has many buttons, many corners, wheels. If I had to take it to a room with a COVID-19 patient, before and afterwards, I will have to clean it thoroughly, all the machine, and that would take me time. As I had more than 10 patients in a box which I'm in charge every time I go to work, I need to do as many ultrasounds as I can. And having that card-based machine, sometimes it's difficult to go and do it. And also because there's cables, there's probes, there's many things that makes it difficult to carry it. So this is what I use. It's a handheld device connected to my cell phone, and I use a cover. And as you can see here, the entire system is covered. And then what I do is to put my gear, my personal protective equipment, avoid to put something like this. It's wrong. Even if it's only a suspicious case, you should put the whole protective equipment. And the problem comes when the number of patients increases. We don't have this type of gears to put on for every patient as we should. But actually in my hospital, after the first week, we hadn't anymore this type of protective equipment, and we had to use something in between, which is this one. And even for confirmed or suspected cases, I always put the whole equipment. And even if I had the disease before and I'm now immunized to COVID-19, I will still put the whole equipment. This is what we use to clean the device. This is an enzymatic cleanser. It's the Vircon, which kills viruses, and that's what we use for all the instruments, also for the sphygmomanometers to take blood pressure. And this is another cleanser that we use to clean what it is inside the cover, the ultrasound probe and the screen cell phone. Be careful with gel, as the bottle itself can carry the virus and can get contaminated. So every time I go to the room, I use single-use packages or just syringes filled with the gel. So every time I go out from the patient's room, I will throw everything away. So I don't carry any chances, any threat for any other patients. Treat the ultrasound device as another extension of your personal protective equipment. So if we remind how we put on the PPE and how we remove the PPE, having the ultrasound device as another step from the removing part, I will need an extra glove to be able to remove it safely. So what's the protocol I use in COVID? First, before entering the room, I set up the machine, all the configuration about depth, gain. So afterwards, when I'm scanning, I'm not manipulating at all the ultrasound, but only covering the protocol, the scan of my patient. I use a system of 3 basins. The first one is the one on the right side of the screen. That one is the one I take inside the room. The second one is outside the room, but in the contaminated area. And the third one is in the clean area. So what I do is to go inside the room. I scan my patient. Afterwards, I clean it and put it in the second basin, which is filled of the detergent, the Virkon to clean it, and then I let it dry and go to the next patient. As soon as I finish my round of all my patients, what I do then is to leave it in the third basin in the clean area where I put the ultrasound device without the cover. And afterwards, in the clean area, I clean it again. So the system I follow is clean it before entering the room and clean it twice after finishing the scan. So if you follow this simple rule, you won't have, you shouldn't have any concerns about the spreading the COVID. The same goes for the car-based system. So here you see the third basin, how I put my cell phone ultrasound probe inside the clean one. As you can see, the cord touched the floor, which is contaminated. So I had to clean it after that twice. Another tip is to use an abbreviated protocol in these patients. Don't try to take fancy measures about diastology or the heart pressures. What we want to see if if there's a big significant involvement. So what I do is to not very sick patients, healthy patients with mild symptoms, I will start my scan at the lower posterior bases of the lungs, at this place where I'm putting right now my probe. And to see the heart, I will start with a subxiphoid view. As many of these patients have pericardial effusion, and in this view, I can take a look to the inferior vena cava and also to take a look to the subxiphoid 4 chambers. And in my posterior lobes, anyone who is mildly symptomatic will initiate the lung involvement at this area. Let me go you through all the findings we can have in this disease. First, the first finding we will have is the irregular pleural line. It is a common mistake to call this a thickened pleural line, but as the pleural line is an artifact, we can see it's irregular, but we cannot measure it since this is not a real pleura. This is not the parietal or the visceral pleura, but just the artifact it gives. So we see it's kind of irregular, like thickened. And then the next following artifact is the scattered B lines. As you see here, is the vertical artifact, which goes from the pleural line till the bottom of the screen without fading and erasing the A lines as they go through. That gives as the disease progresses, we can see confluent B lines. The confluent B lines probably is one of the findings more specific for viral illnesses. If you see these confluent B lines in a healthy patient, and if it's bilateral, be very concerned that even if you have a normal chest X-ray, a normal PCR, a negative PCR test for COVID-19, definitely I will be highly suspicious of having a COVID-19 patient. And then we have the small consolidations, which are these hypoechoic images right below at the pleural line. I found that the small consolidations, this kind of small consolidations, quite symptomatic. As I could recall from my own disease, anytime I had a worsening in my symptoms, one or two of these consolidations appear. And even though in many reports we know that pleural effusion is seldomly seen in using ultrasound, as it is more specific to find small amounts of pleural effusion, I found it quite common to see this kind of small pleural effusions that probably in a CT scan we wouldn't be able to see them. So the protocol I follow to scan a COVID-19 patient is I'm not able to scan all the lung surface. So what I do is to divide it into 4 areas, 2 anterior, 2 lateral, and then 2 posterior. And in this fashion, I know that in this area, in the inferior posterior, is where we will find the initial findings of the disease, and then it will move lateral, and rarely we will see it significantly affected anterior areas. I have seen many sick patients with more affected anterior areas, but it's not something you would expect at the beginning. Probably as the disease worsens, especially during the second week, and in the most critical patients, we will see more anterior affected areas. So here we have a patient. She is in her 3rd day from symptom initiation, and she came to the emergency department with a low-grade fever and dry cough. The X-ray was normal, the lung auscultation was normal, the PCR was negative, and this is the lung ultrasound. So how did I manage this patient? I treated like a COVID-19 patient. And 4 days later, after this visit, she came back to the emergency department due to shortness of breath. At that time, we repeated the PCR, and it was positive. How can we use POCUS in the follow-up of these patients? I will use it anytime I'm considering doing an X-ray, anytime I'm concerned about a false negative test, in patients where I'm thinking about admitting them or discharging them from the emergency department. Anytime my patient have a worsening in their symptoms, and of course, to guide any procedure. So an easy rule to follow, as the lung ultrasound is really easy to apply, as we have only 4 findings to look for. The first one is the irregular pleural line. and just the ABC to look for A lines. This is the normal pattern that we will find in really, really early patients who don't have lung involvement. Then we have B, the scattered B lines, the confluent B lines, C, the small consolidations, and D, the pleural effusion. So what I need to do is to describe the I, A, B, C, D of these patients during the follow-up. In these four, we could say, four areas in the anterior and lateral and the two posterior, which makes a 12th area to explore during every time. So we can divide the findings according to the stage of the disease. So when we have the viral infection, when the virus is in my throat, in my nose, and is starting to get into the lungs, at that point we have mild symptoms like any cold or flu-like symptoms. This is my different lung ultrasound in different patients. At this stage, we see the first one didn't have any findings. The second patient in day one had a single B line, and the third one didn't have anything at all. So when we start to see the lung abnormalities, what we will see in our patients, they started to have it from day 4. The patient 1 started to have some subpleural consolidation, a thickening in the pleural line with some B lines. The second one had confluent B lines, and the third one had some B lines. I apologize for that interruption. And on day 8, we started to see in this patient some more progression of the lung findings with confluent B lines across both thorax. On day 14, there was still new findings in these patients, in patient 1 and patient 2. As patient 3 didn't have any more symptoms, we see that she has the most clear, normal lung A-line pattern. On day 16, the patient 1 and patient 2 didn't have any symptoms, but they still had some irregular pleural line and B lines. So what we see here is that with following the days, we have some dynamic changes. Now let's see if can help us during the monitorization, during the follow-up, if the lung ultrasound can tell us the complications. So here we have on patient 1 that after day 16 didn't have any symptoms at all, had a sudden change in his status, had a worsening in his symptoms, and what we see here is on the right screen a new lung consolidation. So in this change in his situation, we were concerned about a bacterial infection and started with some antibiotics with improvement in his symptoms. And this is another complication. This patient had, this one is the patient 3, and had in the 4th day of symptom onset, started to feel a pleuritic chest pain without any abnormal cardiac auscultation, and had this focus finding. We see a pericardial effusion in this context, which would make sense that this patient had a acute pericarditis. That sounds rare, as we see the most common cause for pericarditis is viral. So we treat her with colchicine with an improvement in her symptoms. This is another complication. We don't see lung sliding in one of for COVID-19 patients, and since he started with sudden onset shortness of breath and pleuritic chest pain, we immediately we did a CT scan, see that the pneumothorax size was big, and we place a chest tube. And here we have, sorry for the delay, yes. Now we have, this is another complication seen in these patients. This is the myocardiopathy. We see a low ejection fraction in one of our patients who developed a heart failure after getting the infection. This patient had, before getting the viral infection, had a dilated myocardiopathy, but with a ejection fraction more or less preserved. But after the infection, got much worse. And here we have the typical findings for a bacterial superinfection. As I would be concerned to see in a CT scan only one lobar consolidation, big consolidation, so I will be concerned with a lung ultrasound where I can see a big hepatinization, a big consolidation in the thorax. That would be suggesting that there's a bacterial origin from the worsening of the symptoms. So I would treat this finding in this patient, in this context, as a pneumonia with antibiotics. And one of the most fair complications during the second week, the acute respiratory distress syndrome. As the findings look like this viral illness as well, what I would expect to see in this patient with ARDS is that BMP, if it's below 100 or the inferior vena cava is below 1 centimeter, I would be concerned about this disease, ARDS. Although if it's above that, it still can be possible. And what I will find is that, especially in anterior areas of the lungs, I will see spare areas with confluent V lines and subpleural consolidations. I complete this exam with a cardiac ultrasound, and I will find that the heart is, the ejection fraction is preserved most of the time. So this is to differentiate from the finding from a heart failure patient. Heart failure patient, we have an abnormal ejection fraction most of the time, and then we have a thin pleural line with the V lines affecting most the posterior and the median lobes, and not that often the apical or the anterior lobes. Another common complication in these patients, DVT and PE. Easily we can move or probe down the waist and see in the femoral area if we find a clot in the femoral or in the popliteal veins. And what about the resolution, the last part of the follow-up? This is day 20 from our 2 patients that we started to follow up. And on day 20, after initiating the antibiotics, the patient 1 didn't have any symptoms at all. Patient 3 was still doing okay. Patient 2 didn't get to this point yet. And on day 28, we see that there's no complications seen so far, no new findings so far. So what we can tell after this is that this is a very dynamic disease where the ultrasound can help us to monitor the findings, how these findings change through time, and how to early detect the complications. And what about to guide therapy? Is it useful at all? So as you recognize this diagram that is used in many presentations, we know that from this disease, we can divide in 3 clinical stages. The first clinical stage is the viral infection, the viral response, which gives you a more flu, cold-like symptoms. And then from stage 2, there's a systemic inflammatory response. So in the first stage, we will use antiviral medications, and in stage 2 and 3, we will use anti-inflammatory immunosuppressant medications. So as I said, we have in this early viral infection mild symptoms, low-grade fever, dry cough, headache, diarrhea, weakness. With normal X-ray, we can find lymphopenia, usually a normal D-dimer, maybe a slightly raised LDH. And there are many medications we can use at this stage. I'm not gonna go through them, and as they target different points of the viral infection, we can use them in combination. So during the early viral infection, we can either have some seldom in lung involvement or no involvement at all. So this lung ultrasound will help me to find that we are at this stage. And the usually commonly used drugs in according to our hospital protocol is hydroxychloroquine, Caletra, lopinavir, ritonavir, or remdesivir. When there's a lung involvement, as the patient starts with shortness of breath or chest pain, we start to find in 60% of the cases lung involvement in the chest X-ray. The CRP and the liver enzymes start to raise up. And here what we can find is the irregular pleural line with confluent V lines and sometimes the pleural subpleural consolidation. And here we still can consider hydroxychloroquine. I put into question marks lopinavir, ritonavir, as you all are aware of the New England paper who came out 3-4 weeks ago, saying that after before day 12, this drug still can be useful. So this could help us to target better the patient who might need it, remdesivir. And during the resolution phase, after the second week, after day 14, we can find some, as I showed you the cases before, some areas of hepatinization or consolidation. We could be suggesting sort of bacterial infection, and we use antibiotics, oxygen supplementation. And if my patient reaches this third stage of hyperinflammatory phase, what we will be concerned will be about multi-organ failure, cardiac failure, shock, and ARDS. Here we have an elevation of CRP, LDH, inflammatory markers like ferritin, interleukin-6, D-dimer, procalcitonin, troponin, NT-proBNP. And here, as the ARDS, the most feared complication in this disease that involves the alveoli, we can use the corticosteroids, tocilizumab, anakinra, and of course the mechanical ventilation. What we don't know yet and would be the perfect scenario would be if lung ultrasound could be useful at all to early detect ARDS, or even before ARDS happens, as we could optimize the therapy in these patients. We could put corticosteroids or tocilizumab before reaching to that point, and maybe we could save that patient from getting mechanical ventilation. So right before getting to this stage, to optimize the therapy with these treatments. And don't forget the use of low molecular weight heparin in all these patients, as it seems that it's in the pathophysiology there's an involvement of thrombosis, or at least macrothrombosis. And as we use hydroxychloroquine or even azithromycin in many of these patients, we should at least try to get an EKG before starting this therapy, as this can prolong the QTC interval. And after finishing the therapy, getting another EKG as well. Lopinavir has many drug interactions. We have many pages, web pages, where we can look for them. And there are some contraindicated, totally contraindicated medications. We're using Caletra, like midazolam, brivaraxaban, amiodarone, rifampicin, sildenafil, simvastatin, etc. And tocilizumab is, we should be concerned about using it in serious or active infection or in cancer. And here you have my email address and my Twitter account to feel free to contact me with any questions, with any thoughts, anything you want to comment. So if you have any questions, I will be more than happy to answer them, if I can.
Thank you very much, Chand. That was a very beautiful and very practical presentation of a very one of the cheapest investigative modalities and a non-invasive modality that we have in the current day clinical practice, and how we have used it very practically in treating these patients. Actually, this is the first ever presentation where we have seen any investigation like this, which has been used extensively to treat, to investigate, to diagnose and also follow up these patients. Mohan, who is with me actually, who is the director of the endoscopy division here with us. Mohan, do you have any?
It was very fascinating talk, Dr. Yale, and it was very fascinating to know that in early disease, when patients comes to us with symptoms and we do COVID test with PCR and it turns negative, and you have high clinical suspicion and you go with imaging like CT, and you have shown point of ultrasound, which has clearly shown that even if these changes are present, you can still treat these patients as COVID patients. And my only worry is the ultrasound is an operator-dependent procedure, and the specificity may not be as good as CT scan, though the much advantages like not shifting the patient to CT, not getting radiations are there. But what about the operator-dependent? How is the agreement among various operators saying that okay, this is this?
So this is not a new topic. Lung ultrasound has been with us for many years, almost 30 years. And what we know is that to perform lung ultrasound, you need a learning curve that usually doesn't take much. And as you have seen in my presentation, we have only 4 findings to look for.
Yes.
The irregular pleural line, I, A, the A lines, B lines, C, consolidations, and D, pleural effusion. These 4 findings, it is not like the cardiac ultrasound. You don't need a good window to look for, a good view to look for. We all have the chest open, and it's easy to get that image. Probably what you need is, and is the hardest part of lung ultrasound, is to interpret that A line, that B line, that consolidation. That's the hard part. But now in this moment, any patient who has any of these present findings will for sure be a COVID-19 patient. So we have an easy to apply tool, easy to find findings, and easy to interpret these findings. What you need is to practice with some patients, with some guidance at the beginning, and then easily after 20, 30 scans, you will be more than independent to do it. As the interoperability of this tool, as we have seen in many other diseases like heart failure or in pediatrics for lung consolidations, is really high.
Yes, I agree with you. Yes.
Chen, there are a lot of questions from across the globe actually. We have Dr. Mustafa from Bangladesh who wants to know what is the optimum time of steroid use in COVID pneumonia patients? And an extension of this question is from Dr. Harsh Gulati, who wants to know steroid in inflammatory phase, does it have any role?
Wow, these questions is beyond the lung ultrasound. Right now, there's, as you know, we have a debate about when using the corticosteroids, the time to use them, and the dose to use them. So we believe that right in the before the hyperinflammatory or at the beginning of the inflammatory stage, that would be the best moment to use them. And when that happen, when we have a raise in the inflammatory markers, the CRP, the interleukin-6, the ferritin, and what dose do we use? Well, there's controversy regarding that. Some of my colleagues, they use 250 milligrams of methylprednisolone for 3 days. Some of them use 100 milligrams. So we don't have that data yet to analyze. As we know also in ARDS, non-infectious cause, ARDS, corticosteroids are also useful. We can recall from before this pandemic in the other studies, and in that specific scenario, I will use it as well.
Another question from Dr. Sangram Biradar, actually, he wants to know your experience with this plasma transfusions. What are the indications and what's your experience with the plasma transfusions?
Sorry about that. I have no experience with that yet. They want, in my hematology department from my hospital, they want to start a trial with that. and probably I will have to be a mandatory blood donor supplier for that, but right now we don't have that yet experience, I mean.
Okay, so we'll ask you a question regarding ultrasound only. So regarding the handheld machine, which is not yet approved in India, you have pretty good experience in Madrid, where your Twitter video was very famous when you described how you recovered from the illness and showing the serial ultrasound. That was very nice. Uh, my question to you is, do you use it as a tool for telemedicine, where patients can be taken care by at home, and they can send the ultrasound pictures to the a doctor which is sitting far away? Do you use it, or any protocol which you have in your country?
We haven't explored that yet, but definitely one of the big changes that will come after this pandemic crisis will be definitely telemedicine. We have to potentiate more these tools, and one of the easier to use is ultrasound. Not only for physician apply ultrasound, but even we should consider patient apply ultrasound.
Yes.
We now ask some of the or telemedicine patients that we follow to weight themselves, to put the oxygen saturation, and to tell us the measure. And why not in some near future to ask them to put the probe and to guide them through the chest, how, and then let us, the doctor on the other side of the screen, to interpret that finding. I think it's feasible. We have the electronic devices, the software to apply it, and we should be considering it, if not now, in the near future. What we are doing now is to, in some areas, there's been testing going on with telemedicine tools for physicians, experienced physicians, to non-experienced novice physicians, to guide them through the ultrasound.
Yeah, another question from Dr. Kiran Vishnu, who wants to know, you've shown us very beautifully how the ultrasound is used. He wants to know, how often do you use this in ultrasound in a COVID positive patient? Suppose in a day, do you repeat it once or twice in a day, or do you do it on specified days to look for these changes that you have already documented?
Much easier. Anytime I'm considering ordering an chest X-ray or doing a physical exam, I will first do an ultrasound. So I can do once every time I see my patient. Usually, in a ward, I go only once. And then afterwards, only if there's a change in the status.
And how the findings of an ultrasound change the management? Suppose you find today B lines and tomorrow a subpleural consolidation. So do you change your management based on the findings, or how it guides you in day-to-day clinical practice?
So this is the most controversial part of lung ultrasound during follow-up. As we have seen that we can have patients with lot of lung involvement, and the clinical scenario, the clinical symptoms are improving, and the oxygen saturation is high, and we will leave that as a lung involvement without a clinical correlation and treat it, because in that clinical scenario, without doing anything else, we can have the extremes. A patient without symptoms or mild symptoms and no lung involvement, I will early discharge it, or I will have a patient with mild symptoms and many lung findings, and I will admit it
Yes.
to the hospital. This is one thing where the ultrasound, the monitor of the ultrasound could help me. And another thing is to early detect the complications. If I see a complication correlated to the lung scan and the clinical symptoms of my patient, I will treat that. So with that, what I mean is that there are many ultrasound findings that I will still have to interpret that. The same will be with a CRP where it's high, but maybe for an infection going on, or maybe because of the inflammatory disease itself. So I need to interpret that finding if it's enough to make a clinical decision to change in the management.
Okay.
Thank you so much, Chen. Actually, as a final question, actually, you yourself have gone through this entire crisis, actually. Can you just give us your personal experiences? What has gone through your mind during this entire crisis? I know it's a very difficult...
Thank you. I mean, this experience was the best lesson I could learn before going back to my hospital. It was the perfect timing as I learned how to scan this disease, and I was seeing all the evidence coming out. So right now, because of this period, getting the infection before, I'm able to apply it to all my patients now that I return to work. So my experience with this disease is that it's a really prolonged disease. So it's not a flu that starts and finishes suddenly. No, you can have many waves and waning symptoms. So every time I had this kind of dynamic pattern, what I will do next was a lung ultrasound to keep a look to my findings, to the abnormalities in my lungs, to see if there was anything to be more concerned or should be further tested.
Thank you so much, Chen. Actually, this is the first ever interaction I think we are having with a clinician who is not only involved in the treatment, who succumbed himself, got rid of this COVID was tested negative, and again he has gone back to his clinical practice. Incredible journey during this COVID crisis, Dr. Chen. Big round of applause from all the viewers. Actually, I think it has been one of the beautiful experiences that we have ever encountered. Thank you so much for sharing your experiences. And we from AIG thank all the viewers who are online with this. And I hope you enjoyed this presentation, and we are going to come back to you next Tuesday for the next episode of COVID updates live from Asian Institute of Gastroenterology and AIG hospitals. And with this, myself and Dr. Ramchandani are signing off from Asian Institute of Gastroenterology and AIG hospitals. Thank you so much once again.
Thank you. Thank you, Dr. Yel.
Thank you for your invitation.